intervention may or may not include medications.
Sorry, let me go back to.
Often a common sense back to basics approach is sufficient to provide comfort. Even when medications are administered for comfort control, you may wish to use the other suggestions listed under back to basics to complement the patient's medication regime. Following is a list of common symptoms often seen in terminally ill patients. Your patient may not show signs of all of these symptoms, but most likely exhibit some. Anorexia.
This can I just say something? This is not the anorexia that you think of when usually you hear this word. It's it just means that you're not hungry. You have no appetite. Okay, this is not necessarily that you have the disease where you're starving yourself. This is where you're not hungry. I just want to clarify that.
That's important. Simply stated, anorexia is the lack of interest in food or the lack of desire to eat. Some possible causes include nausea from medications, palliative chemotherapy that sometimes causes a metallic taste in the mouth, constipation caused by medications, decreased fluid intake, or immobility. Depression and anxiety, oral thrush, a fungal infection, dry mouth, possible side effect from certain types of medications, acid reflux, heartburn, dysphagia, painful swallowing or difficulty when swallowing, early satiety.
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 Yes, it's when you get filled very easily, like you take a few bites or a little bit on your plate, and then you're not hungry any longer.
So this can be due to an enlarged liver, declining condition due to disease process. What can be done? Medications. Steroids such as prednisone or dexamethasone,
Yes.
decadrone, are sometimes administered to increase appetite. Corticosteroids can sometimes increase blood sugar levels and should be used carefully, especially if the patient has a history of diabetes mellitus. Often an antacid taken 1 hour before meals is all that is needed if the patient is experiencing heartburn. If oral thrush is the problem, a physician can prescribe an antifungal medication to inhibit fungal growth and enable the patient to swallow more easily. Besides oral thrush, dysphagia can be caused by other factors, such as cancer of the esophagus, radiation therapy to the throat area, or advanced help.
Oh, it's amyotrophic lateral sclerosis, ALS, basically. Another name for it is Lou Gehrig's disease. That was a famous ball player back in the day who had it, and then they named it after him, Lou Gehrig. But basically, it's amyotrophic lateral sclerosis, or ALS.
Amyotrophic lateral sclerosis. Generally, if a person is able to swallow saliva without difficulty, he should be able to sip small amounts of liquids. However, alternative routes of medication other than the oral one may need to be considered. High-dose steroids can sometimes relieve dysphagia temporarily by reducing inflammation. Laxatives and stool softeners may need to be increased if the patient is experiencing anorexia and or nausea due to constipation. The hospice nurse will probably,
Sorry.
where'd it go? That's all right.
Yeah. The nurse.
Will probably check the patient for fecal impaction. Senecote and Colace both come in liquid form and may be easier to swallow than tablets. An antidepressant may need to be prescribed if Anorexia is caused by severe depression. Positive effects may not be seen for several weeks.
Okay, so this is how this chapter runs, that we talk about, the symptom, what it is, and what can be done with by using allopathic medications, either prescription or over the counter. Okay, obviously these over the counter meds like laxatives and stool softeners, things like that. Those are things that the nurse can say, well, you can go to, this pharmacy and that pharmacy, and she'll write down some things you can get just over the counter. You don't need a prescription for it. Okay, as the symptom worsens, she may call the doctor and get a verbal prescription and have him call over to the pharmacy and get it prescribed. Okay, so it depends on the severity of the symptom. After that, then there might be some back to basics that you can do. The nurse and or the caregivers, the family or the Vaishnavas care volunteers. Okay, so that's how this chapter will go. And now we're going to talk about some back to basic things that you might want to try. And you can, anything that you do, you might want to suggest, I would hope. Okay, please suggest to the hospice nurse that, when we were trained to help, these are some ideas that we were given by our hospice nurse. So what do you think about doing this? Okay, never just go in there and say, oh, well, I'm an educated, volunteer, so I'm going to do this. No. Okay, you ask the staff of the hospice, please. Okay, don't just like bop in and decide to do this on your own. So let's go on with reading back to basics. Okay.
Thank you. Thank you, Karina Purashakti. Devidasi, would anyone else like to continue?
Hare Krishna, everybody. I can continue.
Hare Krishna, thank you so much, Greg.
Okay,
Oh, hi, Paul. Greg, how are you?
very well, thank you. Good to see everybody again.
Yeah, welcome back.
Yeah, that's okay. I was in and out last week, but yeah, I heard some of it. It was nice to hear everybody's voice anyway. Very nice.
Good to
Okay,
have you here.
yeah, thank you. Back to basics. Whether or not the hospice nurse and physician feel it necessary to initiate the use of medications for your patient's anorexia, the following interventions may be helpful. Provide mouth care before meals. This is helpful if the patient has persistent dry mouth or has altered taste perception due to medications or chemotherapy. Use either a toothbrush or a toothette. Toothettes are a foam stick applicators. Some have a mild mint flavor. Dip the toothette in water and assist the patient in cleansing his mouth. Prepare the patient's favorite meal and present them in an attractive manner. Pleasant presentation of a meal can improve appetite. Provide meals when the patient desires them, not just at meal times. Frequent meals with small portions are sometimes more acceptable to patients with anorexia. Simply by seeing large portions on her plate, a patient may experience nausea. If the patient is depressed or physically weak, attempting to eat large portions may seem like too much of an endeavor.
Yeah, if you've got some big, huge mountain of rice, okay, on somebody's paper plate, with some dal dripping off the side of it, okay, that's not going to be very attractive to somebody that's feeling nauseous and having a hard time eating anything. So make it more attractive, okay? A little bit goes a long way in trying to help somebody feel a little hungry, okay? Little bits. Go ahead. I'm sorry.
Okay, that's okay. Thank you. Avoid strong smelling foods such as cauliflower and cabbage if the patient is experiencing nausea. A bedside commode is being used, remove it from the room at mealtime. Open a window to provide fresh air. Avoid strong smells such as incense and scented candles during mealtime. If the patient has a sore throat or mouth, offer cold foods that are soothing. For a dry mouth, provide cool water or another preferred drink at the bedside and freshen it often. Provide a straw if desired and tolerated by patient. Keep a spoon and small ice chips in a cup at the bedside. This is highly recommended when the patient can no longer tolerate drinking liquids. It provides some fluid intake while soothing a dry mouth and throat. If the patient is experiencing heartburn, keep him in a sitting position for 30 minutes after eating. Prepare foods that are less spicy. See antacid information contained in the medication section. If the patient chokes easily while eating, always have her sit in a 90-degree sitting position. Use plenty of pillows if needed to prop her up during meal times. Be aware of the consistency of foods if choking is a problem. Usually, medium thick preparations are better tolerated than thin foods such as soup. If the patient is able to walk or be transferred with assistance, eating a room other than the sick room may help increase his appetite. Provide smoothies and other liquid supplements that are satisfying as well as nutritious. Below are some suggestions.
You don't have to read the whole recipe, but maybe
No.
just the title. Yeah.
Yeah, sure. High calorie, high protein recipes, high protein or fortified milk, high protein shake, high protein fruit shake, orange buttermilk shake, peanut butter shake, Vaishnav favorites, hot milk, ginger tea, lassi, sweet lassi, fruit lassi, mango date lassi, and high nutrient recipes, date milkshake, fresh cranberry juice, green
That's
smoothie. Oh,
especially good if, I'm sorry, if
yeah.
somebody's having kidney problems. And again, ask the nurse if it's okay. But even Prabhupada recommended it when you're having kidney problems to cleanse out your kidneys.
Should I read that paragraph as well, because it goes into a bit of information about the
Yeah,
cranberry juice and its
sure.
benefits?
Yeah, if you don't
So,
mind.
yeah, cranberries are not only sour but can be bitter as well. Add sugar or a sweetener of choice to make this juice more flavorful. This fruit has moderate levels of vitamin C, dietary fiber, and other nutrients such as manganese and vitamin K. It is contraindicated for consumption if the patient is taking medication warfarin, a blood thinner, due to increased incidence of bruising. Cranberries contain an antibacterial agent called hippuric acid, which acidifies the urine and has long been known for its ability to help treat and prevent urinary tract infections. This tiny fruit reduces the ability of E. coli, the bacteria responsible for 90% of bladder infections, to stick to the bladder wall. Drinking 1 glass of cranberry juice a day can help reduce the risk of urinary tract infections. So we have a green smoothie and a carob smoothie. As a caregiver, you may need to explain to loved ones that a patient's appetite will naturally decrease as the disease process worsens. Often well-meaning family members argue with the patient to eat more because the lack of intake is a harsh reminder that death for the patient is drawing near. Therefore, this struggle is not as much about the patient's decreased appetite as it is about the fear of losing someone dear to them. Eventually, the family will accept the fact that eating and drinking will gradually diminish. In his final days, a terminally ill patient will have no intake at all. He is not starving, but simply coming closer to death. This is natural and part of the dying process. During his last days on earth, Srila Prabhupada exhibited this symptom as well.
Can I ask if anyone has ever been a caregiver to a family member or a close friend, and what you may have experienced when they stopped their eating and drinking? Does anyone want to share that? Is anybody, I don't see if anybody's raising their hand because I'm not seeing anyone but the reader. Greg, I know you're a nurse. Do you have a story about any family member that of a patient you took care of, and how do you ever take care of anyone at the end of life? And then how the family members felt when their loved ones stopped eating and drinking? Have you ever been in that
Yeah,
situation?
yeah, I think it was some time in the past. But yeah, that kind of resonated when reading that out. That family members feel that we must, food is a big comfort for a lot of people. So if people are eating, it means they're soothed and they're comforted, without realizing that, like as it says in the book, when you are nearing the end of life, or nearing death, then the person will cease to want to eat anymore. The body, I guess, doesn't require it.
Yeah.
So yeah, I mean, I haven't kind of personally in hospices or anything like that. I've kind of supported patients primarily in homeless hostels. We've had a couple of patients that died in those environments, but sadly they didn't have any family around to kind of experience that.
Oh, I see. Oh, so you work in community homeless with
Yes,
homeless
yes,
patient. Oh, I
yeah,
see.
yeah. So in supported hostel accommodation and maybe in emergency accommodation.
Yeah.
And
Oh,
then if they
that's
become unwell and they choose to go to the hospice environment, obviously the care would be taken over by the hospice team then.
wow, that must be difficult on many levels.
Mm.
Yeah. So okay, so I'm just wondering.
Kavita raised her hand.
Okay, go
Hare
ahead.
Krishna, Hare Krishna, everybody.
Krishna.
I'm Sangeeta Mataji. I'm just responding to your question.
I
I've
love.
Haribol, I've worked sort of at the bedside a lot in terms of supporting family members. And I've had a number of experiences where, as you write in your book, that as the person declines and their body is shutting down, their intake diminishes. And that can be a source of huge anxiety and distress for families. And I've had, families come and say, well, the person is dying of thirst or they're starving to death.
Oh, yeah.
And we have to work closely with the families and provide them with some good psychoeducation so they understand, that the person is comfortable and that this is a natural process of the body shutting down. The organs are shutting down, the body is failing, and by nature of that process, they don't feel hungry or thirsty, and that we encourage them, to do the mouth care and just to provide whatever kind of comfort they can and ensure that the pain is managed well. but to support to the family members at that time is very important, because it's incredibly distressing. And just personally, caring for my mom at this point, I'm almost hyper vigilant around her intake, because I know that when she's not eating, it's not a good sign, and she's really failing at this point. And just sort of understanding that that's part of what happens. Also, of course, when pain is not managed well, and the digestion isn't working, and the drugs are constipating, all of the things that come with sort of managing the symptoms of end-of-life care. So I think the psycho-ed piece is really important to help family members and to assuage and comfort them, because it's so distressing. It can be so distressing. Anyway.
Yes, thank you so much for sharing all of that. That's amazing. I'm sorry that your family's going through this. I'm sorry you're going through it. But people in general, no matter what culture we come from, we tend to show our love for family and people in general with food. My grandparents were from Kiev, which was known as Russia back then, and they showed their love by feeding people. My grandmother constantly fed the whole neighborhood, and that's how she showed her love for everyone. And she couldn't stand it if someone was not able to eat. If they were sick and couldn't eat something, she couldn't take that. She felt it was a rejection of her love. So I explain to families how there's many different ways to show your love, and if somebody can't swallow, you have to figure out another way to show their love. So
That's right.
you can take some lotion, you can put it on their hands and in between their fingers. That feels so good. You can brush their hair and do a scalp massage, and so many things you can do to make them comfortable. Change their sheets and have nice, clean, dry sheets, and so many ways. So that we have to do that and teach them how to show their love besides eating.
That's exactly right. That's exactly right. We used to, now this is before all of the restrictions on scent in healthcare. I don't know what it's like elsewhere, but in Canada, there's a lot of, you can't have anything that smells nice. But we used to provide lavender lotion and linen sprays and things to families. So, yes, this person can't eat, but you can rub their feet or rub their hands. Or it also gives families something to do at the bedside, because keeping vigil when someone is dying is it's almost like a marathon in some ways. I mean, we're devotees, so we sort of chant and engage in other activities, but just in general, it can be for people that maybe don't have an affinity with faith or whatever. That's not part of their experience, which is fine. It can be really distressing for them.
Very true. Yeah, thank you very much.
Hare Krishna, Mataji.
Hare Krishna. Is there someone else that would like to start with anxiety? A big one.
Dritri Kopika, would you like to continue reading?
I'm so sorry. Hare Krishna.
Hare Krishna, we hear a lot of echo.
Yes, my audio is giving some problem. I hope I can resolve it.
Oh, turn it up.
It's awful. I'm so sorry. Did I get this right now? Maybe.
We can hear you better now.
Okay, let me try.
Oh no, it's still sorry. No, it's still a lot of echo.
Sorry. Wow.
No worries. Thank you.
Maybe someone else.
Yes, someone else. Thank you though for trying. Who else would
anybody-
like to continue?
I can read for a little while.
Okay.
It's
Katie?
it's Kavi. Oh, sorry.
Oh, Kavita. Okay, thank you so much, Kavita.
Okay, Hare Krishna. I'm reading off my iPhone. So, anxiety. A terminally ill patient often experiences some form of anxiety. Anxious feelings may manifest as insomnia, nightmares, rapid breathing and heart rate, tremors, nausea, abdominal pain, headaches, loss of concentration, and irritability. Possible causes of anxiety may include side effects from medication, fear of dying, actual physical pain or fear of pain, anticipatory grieving over present and future losses, continued denial. Anxiety can increase if the patient is having a difficult time coping with the harsh reality of his terminal condition. I have seen panic attacks in patients who not only denied their prognosis, but were denied they were in anxiety, even though many symptoms were present. As the patient's condition worsens, the causes of anxiety can be as much physiological as psychological. Possible physical conditions include hypoxia, diminished oxygenation associated with impaired oxygen and CO2 exchange, dehydration, electrolyte imbalance, impending cardiac arrest, pneumonia, arrhythmia, anxious confusion due to disease process such as brain metastasis. What can be done? Yeah.
Does
Oh, so-
everybody know what brain metastasis means? If you have cancer in another part of your body and then it spreads to the brain. Metastasis means the cancer has spread somewhere. So in this case, it's spread to the brain. Brain metastasis. Okay, go ahead, please. Thank you.
What can be done? Medications. For anxious depression, the physician may recommend an antidepressant. Depending on the type of antidepressant medication, benefits may not appear for several weeks. Many patients in hospice care are given an anti-anxiety medication such as diazepam, Valium, lorazepam, Ativan, or alprazolam, Xanax. Drowsiness is a common side effect with most anti-anxiety drugs. Oxygen use via nasal, sorry, the screen is moving, sorry. Oxygen use via nasal cannula may be ordered if the patient's anxiety is due to hypoxia or is causing shortness of breath. Back to basics. Pursed lip breathing. Encourage the patient to slowly inhale through his nose and then slowly exhale through his mouth while pressing his lips together, leaving a tiny airspace. This exercise works to relax the caregiver as well. Continue for a few minutes until the patient appears less anxious. It may help the patient if you ask, "What are you most worried about?" This often assists her in focusing on the cause of her uneasiness. If she is agreeable, encourage a discussion to help reduce her anxious feelings. Provide reassurance while creating an atmosphere of loving support and acceptance. Create a spiritual environment according to the patient's desires. Ultimately, only being rightly situated in spiritual life can we completely rid ourselves of material anxiety. Offer to play a favorite recording of chanting or bhajans using a slow volume. Softly read aloud the scriptures. Chant japa together. Become a storyteller. In a calming voice, tell your patient about the Lord's pastimes in Vrindavan. If you, the caregiver, can establish a spiritual, Krishna-conscious atmosphere for your patient, his anxiety will undoubtedly decrease. Hang a favorite picture of Krishna near your patient's bed or place a photo of his favorite deities on the bedside table. Encourage him to meditate on rendering devotional service to the Lord. That's so beautiful.
Mhm.
In the Nectar of Devotion, Srila Prabhupada writes, in the Vishnu Dharma, there is a statement about meditation on the transcendental qualities of the Lord. It is said, Persons who are constantly engaged in Krishna consciousness and who remember the transcendental qualities of the Lord become free from all reactions to sinful activities. And after being so cleansed, they become fit to enter into the kingdom of God. Remind your patient about the story of the Brahmana and the sweet rice, and also in the nectar of devotion. Srila Prabhupada writes, in some of the Puranas, the evidence is given that if someone is simply meditating on devotional activities, he has achieved the desired result and has seen face the Supreme Personality of Godhead. A very brief summary of this story from the Brahma Vaivaratra Purana follows. Once there was a poor Brahmana who lived in the city of Pratishpurana. This humble Brahmana had nothing material to offer the Lord. However, after learning that he could meditate on devotional activities and acquire the same results, he lovingly meditated each day on serving the Lord with great opulence. Fixing his consciousness on Krishna, he meditated on dressing the Lord very beautifully with exquisite clothes made of fine cloth. In his mind, he placed opulent jewelry and crowns on the Lord. He then meditated on cleansing the temple using holy water carried in gold and silver water pots. He continued to meditate on collecting flowers, fruits, incense, and sandalwood pulp to offer the deity. The Brahmana meditated in this way every day for many years. Once he meditated on cooking a pot of sweet rice for Lord Krishna. He knew that sweet rice was tastier when eaten cold, so that the Brahmana wanted to touch it to see if it was fit for eating by the Lord. As soon as he was, my eyes are so bad. As soon as he was meditating on touching the pot, he felt his finger burning in pain. Suddenly his meditation broke. He opened his eyes and looked at his burnt finger. While this was happening, Lord Vishnu, seated in Vaikuntha, began to smile. The Lord sent a transcendental airplane before the Brahmana and brought him back home to the spiritual world. He lived eternally in complete knowledge and bliss. Gosh, that's so lovely.
Isn't that a great story?
Haribol, the reason I'm saying that is because my mom is dying and she is a great, great devotee. And she's so distressed that she can't engage in service anymore. And she did so much service, deity care and prasadam, and she's a nurse as well. And so I'm going to read that part to her.
Please do so. Please do so. What is her name? We'll pray for her.
Is Chintamani Devidasi. She's Gopal Krishna Maharaj's disciple.
Okay, I'll definitely pray for her every day to my Sheilas. I have Krishna Balaram Sheilas. Their names
powerful.
are Kanai Dowji. So I'll pray for her every day, okay?
Thank you, Mataji. That's a beautiful thing.
And this story is a nectar of devotion, and it's a beautiful story that extends far more than what I just wrote.
Okay, I will get my book and I will find it. I think maybe I might read that to her.
Yeah.
Sorry, I'll finish this. Since devotional service is limited only by our lack of desire to perform it, a terminally ill devotee, although physically incapacitated, can perform the most wonderful service to the Lord without even leaving the bed. This will surely reduce his anxiety. Haribol.
Thank you so much.
Hare
Krishna.
Hare Krishna.
Would anyone like to continue?
The ending of that story is that the Brahmin puts his finger in the sweet rice, and it wasn't cold enough; it was hot. Everybody know this story? To tell this one, Rasika, you want to tell it? How he puts his finger in the sweet rice in his mind, in the mind, and then he gets startled because he burns his finger. and he opens up his eyes because his meditation breaks, and he looks at his finger, and his finger's all red and burned. And right then he looks up, and the Swan airplane is coming with the Vishnu Dutas to take him back home to Vaikuntha, to go back to Godhead. It's a beautiful story. I think your mom is really going to love it if you read it directly from Nectar of Devotion, the Brahmin and the sweet rice.
I love this illustration in Srimad Bhagavatam of the
Yeah,
story.
yeah,
Yeah.
it's beautiful.
Yep.
Okay, so everybody's going to pray for mom, okay? So, and we'll think of this story. All right, anybody else want, is the baby okay, Taravali?
Yeah, she just
Oh, no, it's Revati, right? Revati's sick.
Revati and Yamuna.
Oh,
Yeah,
Krishna.
it's okay. It's the season.
Oh,
Okay.
oh, anybody want to read? What are we up to? Bleeding, minor bleeding and major bleeding.
I can read if you like.
Okay.
Bleeding, minor bleeding. Minor bleeding includes superficial skin abrasions, skin tears, and lesions. A terminally ill patient with decreased mobility, impaired nutritional status, and whose circulatory system may not be functioning as it once did may exhibit dry, flaky skin that is vulnerable to bruising and abrasions. Minor bleeding from surface areas can usually be controlled by topical measures. Possible causes of minor bleeding may include disruption of small blood vessels or topical lesions, rubbing or other trauma to fragile wound areas, incorrect repositioning of the patient resulting in skin tears and abrasions, bleeding from the mouth, gums, or nose caused by drying of mucous membranes, can be caused by side effects from medication, chemotherapy, or radiation therapy.
Does everybody know what skin tears are? Boy, we're going to have a bunch of nurses out of this class. You want to explain what a skin tear is, Taravali? Like if we pull a patient and don't lift them properly.
Yeah, so the skin actually can tear. I don't know, like I don't know what other way to explain it. It can be like almost like a wound created from not lifting patient properly because the outer layer of the skin gets stuck to the bed sheet and then kind of separates from the fat area, like the fat tissue. I'm not sure if it makes sense what I'm explaining, but yeah.
Yeah, and the skin, the top layer of the skin will actually tear.
Yeah,
And
yeah.
if there's so much pressure and the staff doesn't turn the patient enough during the day and night, you're supposed to turn them every 2 hours when they're bedridden, then the skin tear will go down and down and down, go deeper and deeper and deeper, and it goes all the way down through the muscle and to the bone. You can actually, I mean, if it gets that bad, then here in America, the facility gets fined because you're neglecting the care of the patient, because they can actually have sepsis, they can go septic and actually die from it. So you really, I mean, you really cannot neglect to turn your patient every couple of hours. It is neglect, and you get a bacterial infection in your blood and called sepsis, and that's it. That can be pretty bad. Not you, but the person you've neglected has to take antibiotics and have wound care, and it can be very, very painful for them. And not good, bad me. Okay, so me bad, right? Me bad. So not a good nursing practice. And so if you're if you are volunteering to take care of a devotee in your community, ask the hospice nurse to show you how to turn them when she or he they're not there. Okay, you want to know the proper way to turn them so their skin doesn't become fragile and tear like that. Because once it tears, the damage can go very deep in through the muscle and in, through down into the bone, to the bone, and it can become very dangerous for the patient. Okay, infection can get through into the blood. Okay, I think we haven't gotten into that yet, but there's a whole section in the book on decubitus ulcers, which are skin tears and all kinds of damage. Okay, like there's little drawings and everything. Okay, right. So who else you were reading, Taravel? You want to finish?
Sure. What can be done? Medications. Generally, a topical ointment such as an over-the-counter triple antibiotic ointment covered with a sterile gauze dressing is all that is required to prevent infection of superficial skin lesions. Every skin irritation, no matter how small, should be brought to the attention of the hospice nurse so it can be assessed and properly treated.
Even if you notice a little tiny, right, Taravel, like a little pinprick, bring it to the attention of the nurse on your
Yeah.
patient. Okay, because it'll get big before you know it.
Yep. If nosebleeds due to dryness become a problem, the physician may order nasal spray to help keep the mucous membranes moist. Nasal dryness and subsequent bleeding can occur if the patient is receiving oxygen via a nasal cannula, nasal prongs. The hospice nurse may recommend humidified oxygen to prevent dryness. Back to basics. If your patient has bleeding, sensitive gums, provide a soft toothbrush or toothhead to brush his teeth. Avoid harsh mouthwash that might cause stinging. If he desires to rinse with the mouthwash, dilute a mild mouthwash with lukewarm water. For dry mouth or tongue, mouth care is required every 2 hours while the patient is awake. It will vary according to the patient's preference, but mouth care for a hospice patient generally consists of brushing the teeth, rinsing with a diluted mild mouthwash, if appropriate, and applying a lubricant such as Vaseline ointment to dry lips to avoid cracking and bleeding. Some patients benefit from rinsing their mouths with a mixture of water and 2% hydrogen peroxide. The taste can be unpleasant, but it is usually effective for cleansing a sore, dry mouth. Dry mouth can be the beginning of oral thrush. Notify the hospice nurse if your patient complains of a dry mouth. When
So if
giving,
your patient has HIV, okay, then a lot of times a lot of those infections will give you dry mouth. Also, diabetes, for sure, your patient's going to have dry mouth with diabetes. Okay, so if they've stopped eating and drinking the last week of their life, you know they're going to have dry mouth. Okay, diabetes gives you a lot of dry mouth. Okay. And
when giving
also,
a,
go ahead. No, go ahead. It's okay.
when giving a bed bath, always use a mild soap and soft cloth. Never rub when drying the skin, but gently pat dry to avoid skin abrasions. Apply gentle lotion, especially to bony prominences. See skincare and giving a bed bath in Chapter 8. If you observe a newly developed minor skin abrasion, cleanse with normal saline or with water and a mild soap. Apply an over-the-counter antibiotic ointment and cover with a sterile gauze dressing, using a first aid paper tape that is gentle on the skin when removed. Cleanse and change the dressing 2 times a day or more if it becomes soiled. I've had patients who are allergic to most types of um, bandage tape, even the paper tape. In this cases, I applied a dab of Vaseline type ointment on all 4 corners of the sterile gauze dressing. Yes. To adhere the dressing to the skin. If you do this, the dressing may need to be replaced more often, but it saves the patient from developing an allergic, where are we? An allergic skin reaction to the tape. Bring any new skin opening to the attention of the hospice nurse during her next visit. Avoid friction wraps against the bottom bed sheet when repositioning or lifting the patient in bed. See how to reposition a patient in Chapter 8. Place a cool mist humidifier in the patient's room to add moisture and help reduce drying of nasal passages. When a patient is receiving oxygen treatment, never place an oil-based agent such as Vaseline in his nostrils in an effort to reduce nasal dryness. It can settle in the lungs and cause pneumonia. As stated above, Vaseline can be applied to dry lips for comfort. If your patient has a nosebleed, epistaxis, remove nasal prongs if the patient is receiving oxygen therapy. Have the patient sit in an upright 90-degree sitting position with the head slightly bent forward. Never have the patient bend his head backwards or he can swallow blood. While he breathes through his mouth, pinch the nostrils just below the bridge of the nose using your thumb and forefinger. Hold for about 5 minutes. Repeat if the bleeding has not stopped. A cold compress may be applied to the forehead or back of the neck. If the bleeding has not stopped in about 20 minutes, notify the hospice nurse. A small amount of bright red rectal bleeding is often a sign of hemorrhoids. Be sure the hospice nurse is made aware of any rectal bleeding, no matter how small an amount. The physician may wish to increase the patient's laxative and stool softener, as well as order a suppository to reduce swelling. A warm sitz bath often soothes the burning and discomfort caused by hemorrhoids.
Okay. All right, so massive bleeding, we'll do that next time.
Yeah, I think we're out of time.
Okay. All right. So everyone, you have a good week and hopefully it won't snow too much where you are. It's gonna snow where we are. All right.
Thank
Take
you
care,
so much.
everyone.
Hare Krishna, everybody.
Thank you.
Have a good
Thank you,
week.
everyone.
Hare
Hari
Krishna.
Bol.
Hari
Hari
Bol.
Krishna. Take care.
Bye.
Hare Krishna.
Hari Bol.
Wait.
Panchakalpa Trubhasya Sindhubhya